I'm here to introduce the next speaker. We have Dr. Subasri Narasimhan. Dr. Narasimhan is a public health social scientist specializing in sexual and reproductive health, maternal and child health, and intimate partner violence in sub-Saharan Africa, Asia, and the southeastern US. She completed her PhD in community health sciences at the University of California, Los Angeles, Fielding School of Public Health, where she was the Bixby Doctoral Fellow, Child and Family Health Trainee, and a Eunice Kennedy Shriver NICHD pre-doctoral trainee. She came to Emory as a postdoc fellow at the Center for Reproductive Health Research in the Southeast, which is RISE, where her work centered on employing mixed and multi-level methodology to study the impact of policy restrictions on abortion provisions and contraceptive use on the health and well-being of people capable of pregnancy. Currently, she is a co-principal investigator on several studies focusing on reproductive health, birth care and support, and abortion, including the Abortion Bans Project, which studies state-level legislature debate on the 6-week abortion bans, for which she received the 2019 Society of Family Planning Emerging Scholar Award, PROVIDA, which examines provisions of medication abortion implementation via telehealth, and a pilot study focused on impact of COVID-19 on experiences of prenatal care, birth support, and delivery for first-time parents. With that, I want to introduce Dr. Subasri Narasimhan to talk about women's perception of COVID-19's impact on psychosocial health and social support, results from the COVID-19 Birth Care and Support Project in Georgia. Welcome.
Thank you. Thank you so much for that intro. I'm joining you all here a little bit early from New Orleans. So I'm excited to present some of the preliminary results, the qualitative preliminary results of this COVID-19 birth care and support work that I do with Dr. Leslie Johnson, who is in the School of Medicine. Sorry, 1 second. Let's start the slideshow. So I am quite excited to have followed Dr. Kramer, who created such an incredible roadmap for trying to understand equity. And the impetus sort of for this study was from some of Dr. Johnson's experience, actually being a first-time parent during COVID-19. And then also, on top of that, us trying to understand what the lived experience of women going through both their pregnancy discovery, their prenatal care, and delivery was like during COVID-19. And so the goal of the COVID-19 birth care and support study was to be a mixed method study where we both look at women's perceptions of their psychosocial indicators, but also to understand what the pregnancy landscape, meaning some of the rituals and some of the milestones around pregnancy, how that felt for women and how the loss of some of those things might have impacted both their psychosocial well-being and then what their social support networks looked like, including were they getting social support and care from from the health systems and health providers that they were going to, or were they looking for social support in other ways? And where were the gaps here as we start to continue to think about how we can move forward in pandemic planning? So in terms of objectives, I'm going to talk a little bit about the connections between COVID-19, the COVID-19 pandemic and the psychosocial health of women, both in the prenatal and postpartum periods. I'm going to describe several of the impacts of this COVID-19 pandemic on psychosocial well-being and social support with evidence from our COVID-19 birth care and support project. And then I'm going to talk a little about areas of psychosocial care and social support improvement for women in these periods as well. And I just, as a caveat, we try to use gender inclusive language, but everybody who was recruited and part of this study were female assigned at birth and identified as women. So we know that experiencing mental health condition in the pregnancy or postpartum period, particularly depression, is pretty common, and depression is usually the most prevalent diagnosis. There's also growing evidence that showed that COVID-19 had extreme and longstanding psychological, physical, social challenges, and those increase both depression and anxiety in pregnant and postpartum people. I think there's continued evidence that is coming out both at population level, large scale quantitative studies, but also in some of these more reflective qualitative studies, which is sort of the work that I'm going to present today. And then finally, infection control measures, although they were contributed to safety, because of the isolation, because of the stress and anxiety of compliance, and because of many other factors, sometimes contributed to these negative maternal mental health outcomes. And during this period, maternal mental health was checked, but wasn't often at the forefront of providers' minds or health systems' minds, which makes sense. So data show that there's been some aggregate data, and that showed relatively high percentages of mental health diagnoses between even early in the pandemic, with interestingly enough, loneliness being one of the things that women cited most often. And we have also seen some recent studies about changes in some of these symptoms before and after COVID. And there have been increases in mild depression, insomnia, and generalized anxiety. So when I'm talking about psychosocial well-being and social support, let me define it for you all. Here, I'm talking about psychosocial well-being as a multidimensional construct that incorporates the physical, economic, social, mental, cultural, and spiritual determinants of health. So just to piggyback off of Dr. Kramer's talk, I think that when we're talking about psychosocial well-being, we're also talking about some of these elements of embodiment that people are socially experiencing as they're going through their lives that are then affecting their health. Psychosocial well-being is really a quality of life indicator. And social support, is the broad term that includes the supportive ways in which people behave in their social environment, and the social needs that they require to thrive. For us, when we discussed social support, we really asked about who were the people that you could call. Did you have people that you called regularly? Did you have regular care? A lot of those were the questions that got at different aspects of social support. So our study really aimed to understand the psychosocial well-being and social support. And then we also really wanted to understand how women navigated and understood the changing healthcare policies and practices that were impacting their prenatal care and their birth care and delivery experiences. I'll talk to you a little bit about, our qualitative sample. But it's particularly unique in this respect to be able to understand and maybe even challenge some of the handle the challenges of some of the healthcare policies. And then the overall goal was really to identify some strategies for addressing some of the mental and physical health needs, particularly when we think about the connections between prenatal care, delivery care, and then postpartum periods. So we actually used non-probability snowball sampling in order to recruit for this study. We looked for people who could become pregnant, who were over age 18, who were pregnant by January 2020 and attended all their birth care and visits after March 2020. About half of our sample both discovered their pregnancy, had all of their care in 2020, and then half of our sample had all of their activities during 2021. Also, all of this sample was from Metro Atlanta. We purposively sampled, meaning that we looked for certain targets to have at least 50% first-time mothers or first-time parents in this, and we also were hoping to reach a target of around 40% of women of color. The reason for this is that we were hoping to see if the experiences of being a first-time parent, and also coupled with some of the unknowns or uncertainties of the pandemic, heightened women's either psychosocial concerns, or just if they seem to have a different experience than people who maybe have already gone through a pregnancy experience. The goal for looking at 40% of women of color was really to mostly understand what it might be like, what people's experiences might be like relative to the information that they're hearing about the maternal mortality crisis. Our data collection really, as I said, involved it's a cross-sectional study. It involved snowball sampling, it's non-probability, and we conducted in-depth interviews. They were semi-structured with a interview guide, and lasted around 60 minutes. Some, in fact, women had a lot to say, so some lasted as long as 90 minutes. And we used a phenomenological approach, and then followed it by a set of interviewer administrated and validated psychosocial questionnaires, the DSM-9 and a few others, which I won't present today because we are still in the process of analyzing. All of these transcripts were audio recorded and transcribed verbatim, and then we used a thematic analysis approach and constant comparative method, meaning that we consistently had meetings looking at the themes to see if people on our team were agreeing in the coding structure. So our sample of the 20 participants for these in-depth interviews was relatively unique in the sense that our sample was highly affluent, I would say. Many of them, were partnered, they had advanced degrees, and when we dug a little bit deeper, they also were relatively, they understood quite a bit about the science of COVID-19. They were in their 30s, around their 30s, so 80% of the sample was 30 to 39. And again, we met our targets for first-time parents. 60% of our sample was first-time parents. And we had about 30% of our sample as Black participants, and Asian American participants, there was only one. Most had private health insurance as well, which meant that they had continuous care. And almost everyone in the sample, 85%, were vaccinated, but there were 3 people that chose not to get vaccinated to date at the time of the survey. And interestingly enough, the majority of those who were vaccinated after delivery. And I can talk to you about the timing of that, whether or not, and we disaggregated by whether or not vaccination status was, or vaccination was available at the time of their delivery. So now I'm going to talk a little bit about the results of this study. So particularly for African American participants in our sample, there was an extremely heightened fear of COVID-19, and that was coupled with the continued calculus of what maternal mortality might look like at their delivery. And so, as one of our African American participants said, "Oh, I was certain I would die. I was like, I'm not like morbid, but I would just go read about how pregnancy is a strain on the system. And I was reading the numbers in other countries and places like that, doing more research than I felt like the US was. And I thought this is going to be the worst case scenario. This is like the worst possible thing that can happen. And I was very afraid of it." So there was a consistent heightened level of fear amongst particularly our African American participants, they described their prenatal care experiences as um, consistently kind of colored by this worry about things going wrong. But overall, in the sample, people were quite afraid because they were highly, um, they were seeking out their own resources and were people who had connection to medicine or public health. And so we're also trying to read even more scientific literature. And that was making them um, that was making their anxiety and concern and worry for what could happen during pregnancy even greater than it would. Um, Participants also described a really complicated calculus that they were undergoing as they faced every challenge during their pregnancy. So mm, this is really embodied by the fact that one person said, one of the biggest challenges that I faced during my pregnancy is that I, as a pregnant person, was not only a pregnant person, I was also this human living through a global pandemic. I was an income earner for my household. I was a wife to an unemployed spouse. I was the mother of a toddler. My identity as a pregnant person, my roles was more than that one role of a pregnant person. And this participant went on to describe how they often felt like some of their needs during pregnancy, particularly their needs for connection, social support, um, were really going unmet both in their household because of the strain, but also during some of their prenatal care visits. They felt a lot of times that they were being given mental health questionnaires, but no one was particularly actually checking in beyond what their, whether or not they were being screened for depression or not. Um, There was also complications in weighing risks and safety. So one participant who worked in public health said, as a person in public health, it was a bit of a conflict because I know how vaccines work. So this person particularly was talking about their calculus of how, whether or not they wanted to get a vaccine in pregnancy. But also now I'm thinking, I'm having to think like a mom and protect my baby as well. So the vaccine works, but is it going to do something to harm my baby? And couple that with pregnant women have the likelihood of going to the ICU and dying. I can't take care of my baby if I'm not there. I can't have a baby if we both die. So the risk to me, eventually, the benefits eventually outweigh the risk because the whole purposes of vaccines are preventative. So this is a long quote, but it really embodies some of the other quotes that we saw around this calculus of vaccine decision making, and that's something else that we are sort of pulling out of our work is how pregnant women were making these decisions around whether or not to get vaccinated, and then also the timing of the vaccination and um, what concerns were going into that. So it's a separate analysis that we're also running. But essentially, this person did get vaccinated in pregnancy, feeling that the benefits of the vaccine would outweigh the risks of that they felt were really going to the ICU after contracting COVID. Most participants describe the loneliness. And so, in the earlier chart of the 64 country study, loneliness was one of the highest things described. And for these pregnant people, they felt lonely in multiple ways throughout their pregnancy, physically, emotionally. Um, I would say I felt lonely a lot of the time. And you don't get normal social gatherings. It was harder to see people in general. It was incredibly lonely after having a baby because then we definitely weren't seeing anyone. So then I think would have been the overarching theme. So this participant said that they, heightened their COVID restrictions after they had their baby. And felt like during their pregnancy, which they delivered in 2020, um, there was a very little information about what was safe in terms of going out with your child or what was safe prior to delivery. So they just sort of sat tight at home, but that made them lose a lot of the social connection, and they felt extremely lonely throughout the pregnancy. Another participant talked about physical loneliness as being the most difficult, particularly in the ritual of pregnancy in the medical system. So the feeling of being alone in the waiting room and being alone doing the other kinds of medical appointments really was salient to this participant. So this was the first time, again, this participant had also had a child, so they had no other prior experience except through movies and television in which they believed that there would be other people, enjoying this experience in the medical setting with them. So another that participant said, I actually had a thought while I was sitting there waiting for the physician to come up to set up the ultrasound and everything, that I was there alone. And it was the first time I had a feeling of just being alone. This loss of pregnancy rituals actually had quite psychosocial impact on people. Many of the participants, and this was surprising to us, described this loss of what they believed pregnancy was going to be like um, as very difficult. Many of them had anticipated and expected many kinds of celebrations and rituals, and the loss of those really created greater anxiety and depression. Um, those are disappointing things, as one participant said. To not be able to have your partner with you for joy or for total disappointment and heartbreak. And so, yeah, I hate to think about the impact it had on people. And then another participant said, I definitely expected my husband to be able to go with me to the appointment. And that's kind of like what you see. You think your partner will be there. You see it on TV, you see it in the movies, you read about it, whatever. Like you think you're going to be sitting there, they're going to be sitting there next to you, and they're going to get the experience, to experience all the same things that you do. And this is, I think, an important one because sometimes there's a central focus on the experience of only the pregnant women, which is extremely important. But some of our participants also talked about the loss of experience that their partners felt. And so often the partners who were unable to go to medical appointments, who were unable to set up baby showers or to sort of do these kinds of ritualistic things, didn't really feel like there was a pregnancy progressing until they were in the delivery room, and if they were able to be there. So they also felt that there was sort of a loss of family connection or family ritual as well. For some participants, they talked about how care was very unexpectedly disjointed for them, and they felt, for some of the participants who had children before, they felt like there was so much longer waiting periods between when they discovered they're pregnant and then when they were able to go in for an appointment. But what really bothered them was they were unable to understand what the explanation of that was. So for one participant who had another child, who was 2 at the time, said, and the care team didn't want to see me until like 7 or 8 weeks after my pregnancy discovery, which was surprising to me because the last time I came in and they did the confirmation, the blood tests, but they were trying, I think, to start to lower the numbers of people in the office and spread out the appointments. This participant linked it to COVID, but then what kind of went on to say it would have been helpful if they had told me if this was an infection control measure or if I was just not a high risk pregnancy, so I could sort of understand the rationale that the hospital was using. Another person said, I did end up going to the confirmation appointment, and then every other appointment was telehealth, which was weird. I was just used to, with my first pregnancy, these hands-on stuff happening. So that disconnection between going to the clinic to have some of these pregnancy medical appointments was also really unexpected. And many of the participants talked about how they would have loved to have had a mixture of some of these high touch sort of experiences, or just a general explanation that, this is because of COVID-19 and we are trying our best to control infection. So provider communication about COVID was really one of the areas that almost all participants described as sort of, they felt very disjointed. The providers, odd enough, I don't think they verbalized anything like any precautions around COVID and pregnancy, besides like having signs up that you must wear a mask or sign in and put this pen to an unsanitized bucket. I don't think they had any information about it at the time. I did not remember seeing any pamphlets of the OBGYN. My midwife was the same. They really didn't provide any information on it. So some of our participants talked about trying to use their providers as COVID-19 sort of like unfolded between 2020 and 2021 as sounding boards for some of the information that they had gathered from outside, but felt like providers were really reluctant to talk about it at the time. So we can discuss in those results how, maybe the communication aspects of this time could be task shifted, or could have been better, rolled out, in the sense that a lot of the participants just felt like they didn't know who they could talk to about some of the things that they had heard, or even just have an acknowledgement that things are constantly changing and we don't necessarily have the exact information. Delivery policies, as many of you know, were rapidly changing, and this was experienced by almost all participants as well. Many of them started off with very clear birth plans, which changed in a range of one time. There was one type of change to someone who said like there were 10 plus changes between the time that I was sort of like later in my pregnancy to when I actually delivered. So as one participant said, my plan, and in my plan, it would have been nice to have my mom and husband. And then we had this nice wave that peaked. They're talking about COVID cases wave, because this was September. Then we had another wave that happened, and I think that was in August, and they changed the policy back to one person, no visitors. And so we had to change the plan. So I was able to at least assure my mom, I wanted you to be there, but I can't have you there. And so that was just too bad. So this participant just said, I accepted it, that these things kind of changed, but it was relatively disappointing both to the pregnant people and to their families. And again, it goes back to this idea of the pregnancy ritual. Many of the participants said that sort of not being able to have other people in the waiting room or in the delivery room was really kind of a loss of some of these rituals that they were expecting. So there was particularly a real need in this for care connection in the postpartum period. And I think this is one really important finding I'd like to highlight, because most women said that the 6-week appointment was way too long, given how they felt in terms of mental stress. They felt like they needed at least another check-in, even if it was over the phone prior to the 6-week appointment. And so, as one person said, it was emotionally hard and mentally hard, all of this stuff. I didn't have anyone checking in on me. But I also don't know if I had delivered in the hospital, if they would have been checking in on me anyway. I didn't really connect with any other pregnant women. And that lack of connection with other pregnant women was also something that was cited by many of our participants as being very difficult. And as another participant said, there's always been kind of this gap between delivery. This person had 2 other prior children. There was always kind of this gap between when you delivery and then in the near 6 weeks of being like on your own. We'll see you in 6 weeks. It would have been nice if my doctor had called and checked on me to say, how are you doing? But they didn't even know, and I didn't have the bandwidth to try to reach out to anyone. So the care connection in the postpartum period, it was often an impetus on the part of the pregnant person to figure out a plan to create connection. And some of the participants discussed how they wished that their health systems had facilitated some of these connections, either to other pregnant people or even just to a social work check-in. Um, so some people were proactive and they created safe support system innovations, which is what we call them. So one person had a Facebook group that eventually ended up being a huge part of their support system. I wish I discovered the Facebook group sooner because it's so helpful. Sometimes your doctors tell you things and you're like, I don't know if I really buy that. Um, you can find support and answers there and people share their experiences. It's not like you're going there looking for facts. Sometimes you're going there looking for social support of someone who's gone through the experience. Whatever can be done to help support and pregnant women during the experience would be great. Also, providers on social media became a really, really big part of people's information pipeline. And I think this is important to highlight because we sort of need to be keeping an eye on who the providers that are becoming very large on social media are, because they're reaching a lot of the pregnant people in our communities. So on social media, I saw people sharing things, providers especially, who said, I'm a provider and I'm a pregnant person, and I choose to get the vaccine for these reasons. And if you want to send me a private message and discuss your situation, I'm happy to talk with you. This person said that she actually did privately message the social media, uh, provider after, uh, after seeing their sort of video online and vetting what their credentials were, and had a conversation with them about the vaccine, and ultimately decided that their next appointment to accept a vaccination. So, here's where I'm going to kind of draw to a close so that we sort of have a little bit of time. You know, um, as I'm positioning this, it's not to problematize the health system completely or providers completely. What we're kind of trying to lift up here is that there were, in those earlier pandemic periods, there was clearly a lot of different factors that changed the communication pipeline, and a lot of different social connection areas that have shown improvement. But some of this work really highlights the need for thinking through, as we're doing continued infection control measures, how we can create more innovative ways to socially support the psychosocial well-being of pregnant people, both in the prenatal and postpartum periods, because they are asking for things, for check-ins that are about their holistic lives and how they're doing, and not just whether or not they're meeting the criteria for certain diagnoses. So consistent with the emerging research, those who are pregnant and seeking care during COVID-19 experienced this really unique intersection of very exceptional circumstances. They had really complicated risk benefit calculations that involved multiple people in their families, themselves, and sometimes their fetus. And there was a lot of physical isolation and emotional loneliness, which heightened a lot of the stress. Participants felt that they needed greater connection with their health providers, greater communication with their health providers, in order to accurately make those decisions or appropriately make decisions. And then women highlighted experiences of developing and maintaining communities of support. Those communities of support, both online and in more safe spaces, provided insight into information sharing in this population, especially during emergencies. I feel like this lays the foundation for future interventions for COVID-19 and for perinatal health education in clinical and community settings. So our recommendations is that we need to see who patient define as their support people, and look at that broadly and not, in a narrow way. So perhaps, doing more research on who patients are going to both in, traditional areas, and maybe more in innovative areas that support people. Improved research needs to be done on those virtual knowledge exchange platforms and the perinatal and postpartum prenatal resources that are being provided on those platforms. And then we need at least one more check-in before the 6 weeks. So updated policies that acknowledge the unique experience of patients and account for individual needs. Uh, Virtual and safe ways to facilitate knowledge, especially amongst mothers, to address information gaps. Additional COVID-19 perinatal resources from providers for parents, and increased provider check-ins. For example, having a mental health professional at all postpartum visits in order to discuss or even offering that. Um, you know, what these study results taken together show is that people, particularly perinatal people immediately at the end of their delivery, need to have access to multiple domains of social support. And we need to consider improvement for both the mother's physical and mental health needs in the context of this ongoing pandemic. So thank you so much for the MCH Center of Excellence for this small grant award. And also thank you so much to Leslie Johnson for being a great co-PI, and Joy Henry and India Stevenson for their assistance in creating this study.